So next we have a remarkable panel discussion on the rise of digital health ecosystems. Let me introduce to you our respected panelists for this session. Mr. Anil Dobhal, Global Chief Technology Officer, Doceree, Ms. Khushboo Aggarwal, Founder, Zyla Health, Mr. Makarand, Kulkarni, Project Management Officer, Strategic Projects, Sanofi, Mr. Pankaj, Nawani, Chief Business Officer, CarePal Secure, and Dr. Tavpritesh, Sethi, Associate Professor, IIIT Delhi. And to moderate this session, we would like to call upon Ms. Dipakshi Mehandru, Director for Government Affairs and Public Policy, Dell Technologies. May I please hand over these proceedings now to Ms. Dipakshi Mehandru.
I'm not sure whether we need the mic. We can be actually loud enough for the... Oh, okay. So then I definitely need to use the mic. So, good afternoon to the few people who are here, and good afternoon everybody right here. It is actually, when I was just thinking about, how to open this particular panel, given that we are such an eclectic group, everybody is almost from a different side of things on digital ecosystem. I think it would be really cliched to initiate and say that, COVID was the spike when we talk about healthcare. But then when I was thinking about this, I was like, if actually we don't talk about COVID, that would also in itself be it would not be fair, because that in itself was also one of the places where public sector, private sector, different stakeholders alike realize that we have a crumbling infrastructure, our solutions are, let's say, not really in that place. But while COVID did expose the fault lines, like how, there were major red herrings, or for that matter, I would say there were major silver linings that came out of the discussion. We realized that probably because we were leapfrogging as a country, we could redo certain systems better than what we would have, let's say, leapt from 1.0 to 2.0 and then 3.0. We actually picked up the learnings from 2.0 and straight away launched the 3.0, which really helped in a lot of frames of reference. So whether we talk about the innovation, whether we talk about vaccines, whether we talk about the tracking mechanisms, whether we talk about this new focus on preventive healthcare, which was unfortunately, I think as a society, it was really missing, barring the few elite. And it did not really come as a surprise, where in about 2017, the healthcare tech ecosystem was about $500 million. Today, as a market size, or for that matter, the last year, it was at about $10 billion of an industry. That CAGR is unprecedented. From being a non-entity in the larger group of, or the global scenario, we do expect that by 2025, India would contribute to about 3%. So against that backdrop, and we have a very, very diverse range of panelists here today, from who have started up, who have been debating these questions, who represent the corporate sector, and the idea of this panel, I just thought, was that, we'll keep it very, very conversational and really pull in where, let's say, while we have learnings, but perhaps, the focus would also be, where do we go from here? How do we really build a more equitable offering, or for that matter, just ensure that nobody is left behind, while not letting the innovation strand of it go. So at that one, let me start the panel perhaps by directing a question to Makarand, right? When we talk about the healthcare segment, of course, and it has a lot of tentacles, pharmaceuticals is one big arena there. And pharma, perhaps, especially after a lot of policies that have come out in the last 2 to 3 years, it's rife with There are a lot of startups, there are a lot of new offerings. The wheel is breaking and getting created as we speak. But I'm also mindful technology is perhaps just an enabler there. So while technology is an enabler, I'd love for you to share with the group, what are your thoughts on the post-pandemic? What have been the key learnings from pandemic? How did pharmaceutical sector really incorporate those? And therefore, what do you feel are the strategic priorities as we sit here and deliberate that today? Makarand.
Thanks, Dipakshi, for starting off with this critical question. Very difficult to answer in a way, because I'm just trying to articulate my thoughts, because there's so much. If I just close my eyes and look back, what's happened over a few years, I think my first response is COVID has really shaken us up in many ways, in a positive sense, because it has reminded us that pharmaceuticals is not a supplier of medication to the public. It has forced us positively to reinvent our role. Now we look at ourselves as partners of public in healthcare, and not just as manufacturing and logistics suppliers of medication. And I know many of my friends may not like what I'm saying this, but that's been by and large true, because we were in that frenzy, but I think, of course, we know that we are an industry which works for a cause, for touching human lives, but I think this is what we could really see in post-pandemic. That's first. What has changed for us, besides obviously the Zoom meetings and less of travel, I'll not go there, but what's really changed for us is, as an industry, is speed. Because, our timelines are totally changed. From the lab to the market, be it a vaccine or be it a drug, how to make it happen fast, because it's about saving lives. Sorry. So launching products is not about only adding to your portfolio, but launching products means on time is saving lives, is something which every one of us is mindful of. Second point is, whatever we do for the patient, it's not only for the cure or disease management, but we need to play a role in prevention. We have a responsibility in educating the patients, is what we feel. And I think that's true, because if you see, other than the government and the authorities, which we always look up to educate us, so-called, the only other sector which can really do and has the credibility is the pharmaceutical companies, because we are supposed to have the knowledge and also the infrastructure to educate people. So that's what we feel is our responsibility, and we should do that, and we are trying to do it. So speed, awareness, and third most important thing is partnerships. Because the industry always banked upon itself for innovation, getting more talent, going to the lab and working. COVID has taught us that if you have to be fast and speedy and save lives, you need to reach out to partners, acquire technology, acquire expertise, one example I can give you about ourselves. Sanofi is, we have in these COVID times, we partnered with one of our biggest competitors, which is GSK. So this is what happens, I think I see that as a good sign. So partnering with your competition, with health tech startups, and getting close to technology. So, and finally, also pharma is now open to business models which they have never thought about. Initially, it was about a service which a pharma is to offer as a pill plus service. We just had a conversation. Now, a lot of pharma companies, especially fast-growing Indian pharma companies, they are looking at not only offering it as a service, but venturing into different business models. We have pharma companies who have started within no time digital pathology. They have entered telemedicine, and nothing wrong, but they have also, we have, a lot of them are manufacturing now accessories right from masks to sanitizers. So this is what it is. I could have never imagined that, especially our sector, taking decisions fast, launching businesses, making it successful. A lot has changed, and coming to the theme of the day, so be it speed, partnerships, new business models, digital is the central piece of everything. And I think we have done that. Finally, I don't want to enter Anil's area, but we have also started going digital in a big way when it came to HCP engagement, to the access to doctors and reach. So I think that's in a nutshell from my side.
Thank you. At that point, actually, Makarand, and I'm tempted to ask a follow-up question on what you said. You said, especially, and I was taking down that speed has improved across the value chain of pharmaceuticals today, right? Given that a lot of audience I get to know is interested in the digital side of a traditional business perhaps also, from a speed lens, how do you see that data is helping you real-time, predictive? Where do you see this digitization helping you the most as a low-hanging fruit?
If you want to be very candid, I think there's a long way to go for us. There is a lot which can happen. We talk a lot about biomarkers, for instance, biomarkers, data. I think we haven't even touched the surface when it comes to biomarkers and data. The pharma industry is now getting into a mindset of being mindful about the data what we have, because there's been a lot of data which we have been playing with, but not really structuring it, not really using it, and I always have this side conversations with our colleagues that it won't be soon that someone outside the industry will hit us very hard that look, I have got made better data than what you have. And that's happening. So I think, but that's good news because we are here to learn from other industries. To answer your question, that yes, there is a lot of scope for pharma to be the custodian of the data and the analytics and the biomarkers, but we haven't done that. Good news is that we have started doing it. And I may just move a little step forward, is that going forward, pharma can, according to me, play a big role. Not only for data which we own, but there is a lot of data which is generated and owned by, say, government hospitals, municipal hospitals. Every patient treated in a clinic or a hospital is also generates a lot of data. And pharmaceuticals as an industry has been very close to the HCP world, to the hospital world, both government and private sector. I think we as an industry can work along with them to really enrich and do something on this.
No, thank you for the opening remarks. And on that one, since you also mentioned about how different industries might also, come in and just shake the system, there is a very strong belief that I think most of us in the tech industry also hold. And that is something that I also started with. Tech is perhaps an enabler, right? And any strong change management system, especially where there are a significant few that are ahead of the curve, but a bulk of the people who have to ensure or get that change going, we have not really invested, let's say, in that capacity building that much right now. Anil, I will segue into you when we talk about healthcare professionals here, right? And Doceree has done a lot of work in a very fragmented market and a very niche work in a very fragmented market. And I'm also assuming that, I know for that matter, and I will not put stats to it because I'm not sure of the stats, healthcare professionals also really pan across this curve. Some would be technologically elite, some would be laggards, but that resistance to change will definitely be there. The newfound importance, and I think they were always important, but the newfound importance that we have on the healthcare professionals today, where they're literally the linking pin across a very fragile healthcare system. What are your keenest learnings, or how would you conceive that? What is now the need of these healthcare professionals when we talk about a very digital world?
Hello. Thank you, Dipakshi. So before jumping into it, I can draw some backgrounds there, at least on the number sides and where we are. So pre-COVID and post-COVID, digital health was, pre-COVID was also available, right? It was there, right? But it came into forefront after COVID hitting it, and especially like when during the lockdown, when the physical meetings, the in-person meetings went away, right? So this all started giving evaluation and probably innovations towards building that stuff, right? So that's how we have started seeing the progress, right? If I speak from number perspective, probably as of today, like we are about 400 million health users, And I think by 2030 we'll be around touching around 1 billion, right? So that's the growth probably we see, and this is only possible when you invest a lot into technology, a lot into digital, make everything accessible with quality and all that. So that's the way, that's the path probably I think should make sense for us. Now coming to the HCP world, engagement of an HCP with the brands, right? It plays a very important role, and let me talk about a Docere as, it's called as Docere. So let me talk about Docere. Docere is an HCP only platform where we engage pharma brands to establish a connect to healthcare professionals. And we have a lot of channels of that particular engagement, right? Generally, we have seen now how the journey starts. Digital has happened on to those network also, where these healthcare professionals are visiting. So we have different channels there. Like we have there's something called as point of care, which is your EHR platforms and EMR platforms, electronic health records and all those. That's where your HCPs comes, and then they have interactions with the patients on those particular sessions. That's one area. Other medium where HCPs enter into this particular area from a network perspective is like you have online medical journals, you have learning platforms specifically for HCPs. So those has been digitalized, right? And it's important how do we tap that HCPs are actually coming into those. That's where Docere as a platform tries to bridge a gap, and we connect the pharma brands to these HCPs via this digital platforms, right? So we have different mechanisms there. We reach out to HCPs and one-on-one basis. It depends upon how the brands wants to approach those things, right? You remember like prior to COVID, we used to have a lot of medical representatives visiting doctors physically. So that really went away, right? So how do we now, as Makarand said, that if they want to launch some drug, they want to promote those particular drugs, where they can reach out and make that connect to, first connect has to be HCPs, and then it goes to the outer world, right? So if it is an HCP, then what's the platform where we can create those engagements, right? That's where the product like us comes in picture. So we create targetings based on 101. We have a pool of HCPs where we can reach out. Similarly, you can also do cohorts kind of stuff, right? So I suppose I can take it with an example probably that Sanofi wants to. Sorry, I'm taking an example, right? That's fair. So Sanofi wants to run a campaign, and they have launched a drug into oncologists, and they want to do some clinical trials on those things. So to establish those clinical trials, they need a connect pool of HCPs. So that's where you define the cohorts. So in this particular thing, the cohorts is what? I'll be reaching out to oncologists, all of them. So what we'll do is we'll create digitally probably we'll create a campaign, we'll execute out on Docere, and then reach out to those HCPs and create those engagements there. So that's another mechanism, right? Third thing probably which we do is like we even reach out to a lot of account. So we do account messagings, right? It's very critical and it's going up. Digitally it is going up, account messaging, right? So from an account messaging perspective, there are so many decisions probably which within an account, apart from HCPs, there are non-HCPs who works very closely with HCPs, take those decisions, right? If medical device has to be issued or some drug has to be approved, right? So all these are like combined decisions which happens as a combination of HCPs. So how do we reach them? So we have tapped that particular market by doing account-based messaging. There's another stuff probably as I would mention, like drugs. In India is I think so it's still cheaper, but if you look at outside India also, the drug costs are very high. So how do we make that affordable for our patients, right? So we have innovated something digitally that we run patient affordability programs out of it, right? So where so for example, like a doctor is running a session and talking to the patient and writing some prescriptions, right? So while making those particular prescriptions, probably what we can do is digitally probably we can enable some discount coupons or from that particular brand for which we've been running it out, and it's HCP taking that particular call that how they want to distribute this particular coupon to those patients in a very live. So think about the coupon is loaded right away when you're making a prescription that is available for disbursement. Right? And then you can do disbursement over email, SMS, WhatsApp, and you can directly send to the pharmacies also, which a patient can. So these are all like digitalized stuff from end-to-end journey. And then when we talk about engagement, why speed is coming to picture? Because we do everything within milliseconds now. So we are promoting things where the response time back to HCPs and engaging them is into milliseconds. And the decision making is very, very fast.
No, so that helps in positioning, where the company that you represent, what they do. But at this point in time, let's say, I will also zoom out slightly, and I would say that there are not a lot of HCPs who would be that digitally savvy. Right? And I will use that as a conduit, let's say, to move to the next part of the larger piece, and I'll pull in Dr. Sethi here, is also around the fact it's very evident that we are a very, very diverse market, right? Not just market, we are a very diverse consumer of healthcare today. We would have elites, and I'm assuming, Anil, these would statistically be the elites who can use the system today, but then as an economy, we are also sitting at a big chunk of people who are at the bottom. Connectivity issues are there, infrastructure issues are there. From a digital transformation perspective, the basis device issues are there, right? From somebody's perspective who has really been researching the maternal, the neonatal, the pediatric health perspective, how do you really perceive this gap that is very different, that's in India and Bharat, really, right? And we always talk about technology as something that's a great leveler. But at the same point in time, the other argument also holds true that those who actually are left behind today will not actually find a lot, they will not probably find a lot of avenues to catch up and come into the digital inclusion net, so to say. It would be great to hear your thoughts on that.
Thanks, Dipakshi. I think that's a very pertinent question, and I will give 3 pieces on this. So the first is basically what we do as a lab. I'm an academician, run a lab at IIIT Delhi. My background is in medicine. I've been doing data science and AI for the last 15 years or so. And we have been increasingly recognizing that to take our technologies that we develop in the lab settings to a deployment setting, it may be commercial, it may be non-commercial, is a completely different ball game altogether, and the last mile challenges are immense. So the first example that I would start with is what we have been very comfortably been able to achieve in a setting which is like All India Institute of Medical Sciences, where I work with the Department of Pediatrics, with the ICUs, and there essentially the questions that we ask are, can I predict which baby is going to crash in the next 24 hours? Using AI models, the first thing that's required is data. Now you may argue that data is something that is at the base of everything that we are trying to do in digital, right? We have a lot of data that as a system we actually generate, but it is routinely lost. So I think the first thing that we need to do to build inclusion is to get the data right. And I use this example that we might think that we are data poor, public hospitals do not have enough data, but actually sometimes it is the question of the will and the requirement of putting in some very basic systems in place. 6 years back, we put together a basic data warehousing platform in the pediatrics ICU, which has now warehoused more than 2 million patient hours of continuously monitored data at AIMS, which allowed us to build predictive models for babies going to crash in the next 24 hours. So that's the example number 1, that if we have to be thinking about inclusion, really look at those small changes, low-hanging fruits, early wins, where we can actually bring in the data in a manner which sets the momentum. Second example is when we don't just stop at technology, we start looking at new models of delivering that technology by bringing in the social structures that we have in India, which are very unique to India. Here I will use the example of an NGO that we work with, the name is Sethi. and it's a Bangalore-based NGO. Essentially, the goal of this project was to learn from data which has been collected by them over the last 15 years in understanding how can we mitigate the spread of HIV in female sex workers. And this is data from 5 different states, and what we learned here was that when we went in, this was supported by Google, and when we went in, we said, oh, we have previously published papers in conferences like AAAI, published in Lancet Global Health, so here is something that we can come in and actually learn models, and then you can start deploying. Over the period of next 1 year, what we realized was, of interacting with them was, no, we were wrong, because we also need to understand how do we deliver the model. So what they came up with, and which was very interesting, was that ways of delivering models in which existing social workers and health workers can be leveraged. So it doesn't really have to be every person owning a mobile phone, which is Android phone. It doesn't have to be every household having the internet connection, but identifying that right person who has the right peer network. So they, for example, run these community organizations, and then essentially these community organizations provide support in the form of things like financial literacy training and so on. So what our models identified was to mitigate HIV transmission. Our AI model told that the financial literacy of a woman was the key factor. And when we looked at it, we thought this might not be the best because we can think of better factors like condom usage and so on, which may be more immediately predictive, right? But then essentially, after running a few round of experiments, we figured out, and they also then came in and said, this seems right, because women who are more empowered financially are also more empowered to say no to unprotected sex. So which means that this was again an eye-opener for us, that AI should actually look at these models which are social technical models. And to bring in inclusion, we need to bring in these factors that can illuminate such findings for us. Unless we have those in the data, we might be actually not looking at the right piece of the puzzle. And the third and last piece that I would talk about, I am very passionate about it, may not directly be related to maternal and child health, but may be related to some things that pharma companies, for example, do, is to how to get the data right that already exist. We work on projects which basically we call them how fair are fair data, findable, accessible, interoperable, and reusable. So a lot of open scientific movement focuses on fair data sets, that we do something, we publish something, we put out our data which are fair. But guess what? We started with COVID-19. It was an initiative supported by the PSA's office in the Delhi Science and Technology Cluster, where we said that we also call it tendering data sets. Can we bring together data sets to help make policy decisions? We were successful in doing that. We were predictive of COVID-19 surges 2 months ahead of time, probably the first model in the world doing that using AI. But what we realized was, if we try to bring in a lot of data sets together, and SBB talked about it, we don't have the right standards. We don't really have the right structures to bring these to basically harmonize these together. So now we have built 5-layered technology model to harmonize these data sets. I'll be happy to share the preprint soon. Essentially, where we say that there's a lot of data available out there. The need is to have the people to really come in and start harmonizing to build insights. And I think that's where inclusion also comes in, because unless we are looking at these very different data from very different lenses, that Africa is depositing some data, India is depositing, Europe is depositing, US is depositing, and then what stands out at the end of the day, or what is different, we can learn from those both, right? So we are a data lab, and essentially learning from data labs. So those are my 3 examples where I would just like to say that it's important to have the structures in place. It's important to have the technology that is low-hanging and puts the data systems in place, and also not just focus on technology as the end-all be-all, but also look at the models which will work with the existing systems in place and take them to the ground level.
On that one, Dr. Sethi, I have a very quick and a very brief after question. That is, you made a very interesting point that, there is a lot of data that exists, a lot of hypotheses perhaps, I'm assuming, also that exist. And today when we talk about a global village really, how easy is it right now, let's say, to take hypothesis from another country and apply those same to here? Because that's also the context of digital public goods. If you could very briefly share your views on that, please.
So I don't have empirical evidence on that, but I think what we are realizing more and more is that, for example, models that work in one country need to be tweaked and put out in another country. So we can learn from something that Rwanda has done. Rwanda can learn from something that we have done. The world can learn from our digital innovations during the COVID-19 times. So we don't have empirical evidence, but I think that's what is the need of the hour. Again, having harmonized interoperable systems is the way to go.
Thank you very much. I'll pick up a strand from there, and Khushboo, I'll come to you. Very evidently, and the last few panelists have also, very evidently focused on the transdisciplinary nature of how digital systems are evolving, right? It's not just a data point, it's not just digital, it's not about digitizing the system. It's about probably going back and even asking or breaking that mold and asking that question on where you can get. And traditionally, a lot of healthcare focused on preventive, now as curative, now it's also preventive. And very evidently, digitizing processes is the easier job. Getting data is easier, what you make of data might be difficult, right? Or might be different. So in your view, while this is just the tip of the iceberg that started digitizing, how do you really digitally transform a larger piece? What does that mean really for offerings? Let's say not an immediate lens, but the lens of the next 3 to 5 years when these technologies are also going to, stabilize and perhaps propagate.
So great question, thank you so much for that, and Dr. Sethi, very, very inspiring. I've had the pleasure to meet him 2-3 times before, always an inspiration. So I think, as Dr. Sethi was mentioning, clean data and data that can be understood, harmonized, is the starting point. From there, what we've learned, so I run a company called Zyla Health. I'll keep sprinkling examples so it's real. What we've learned is that just capturing patient data is not helpful. You have to really go deeper at 2 levels. Number one is standardizing that data, right? And we use at Zyla, given my consulting experience, I knew that data from day one has to be clean. So we codify data into what we call medical coding data sets. So we use ICD-10, LOINC, ATC sort of coding, so that every data point captured is clean metadata and not text string data, right? Once we capture that data, we have a beautiful longitudinal patient file. You imagine, you onboard a patient, so we do chronic disease management pretty extensively. You onboard a patient and you create this beautiful longitudinal patient file. Now at level 2, what we do is we build algorithms and we build technology to correlate the different data points and figure out anomalies, escalate to a human when required, when it needs attention. So imagine someone has leg pain and also reports of hypotassium and is on telmisartan for hypertension, which is high BP. There is a correlation, and a medical professional, a doctor or a paramedic needs to dig deeper into this correlation. So the technology or the algorithm cannot prescribe an intervention or a medicine, but it can find a correlation and it can highlight it to a human so that further action can be taken, right? So what we have done is we have created these algorithms so that even if I have 1 lakh active chronic patients on the platform today who are living and breathing on the platform, my algorithms are working in the background to predict that this patient may be at a risk of chronic kidney disease given the BP trends and the history of smoking, and we need to take action, right? Or this patient, for example, is a diabetic and his father had a heart event at the age of 40, so we must do an echo or TMT as a preventive step before there is an event, because this patient has reported tachycardia pretty frequently with certain chest pain in the past, right? So these simple correlations can actually save lives, and I think that is the future. At a macro level, right? So I spoke about technology, but you rightly said digital is just the tip of the iceberg, and for us to be truly inclusive of the varied sort of diaspora we have in India, it's very important to understand the macro trends. At the macro level, what's happening is, while all of this technology is shaping up, and we're working on secondary prevention space, as we call it, right? At the macro level, there's a lot happening in the payer-provider space, right? So what that means is, in the country or globally, if we have to actually find a sponsor for this care so that you can save lives and you can put people on a very structured care pathway, the incentives have to align. And we've seen globally the incentives of the payers, someone paying for your insurance, is best aligned towards taking care of your health and sponsoring that care even, right? Because that means that, you end up in the hospital lesser, you have lesser complications, and the payer saves claim costs, right? So it's a direct ROI. So what is happening now with Ayushman Bharat is that the country itself, everyone will have a baseline health insurance, and post-COVID, a lot of us have woken up to even private insurance and top-ups. So insurance will become mainstream in India in the next 3 to 5 years. From the 15% adequately insured today, we'll be sitting at a 50-60% adequately insured, and every insurer, be it private or public, will basically provide certain care management to every family, every person, so that they can keep their health under check, right? Life expectancy at the time of independence in India was about 40 years, and now up to 70 years, we'll see it going up to 80 years, right? And on the provider side, we'll see that the payers will be demanding, right? So the government will be demanding to private hospitals, to clinics, to doctors, saying, hey, show me outcome, show me quality, not just volume of care. I will pay you a positive or negative incentive basis the quality. And to enable all of this, what will happen is there'll be a mammoth digital health layer created, a meta layer of care, which every insurer will plug into, which will be the first point of contact for care for every individual. And from there, all tertiary and physical infrastructure will emerge. And that is my dream for Indian healthcare, and that is what we are sort of trying to build at Zyla.
Thank you so much. For that matter, I do have a lot of questions, but I'll come back to you because we actually have an insurer in the room, and I think that's the perfect segue to actually go to Pawan. You said something very interesting, Khushboo, that adequately insured, right? And I'm going to stick with that term. And I think this is nothing new for none of the panelists, not for anybody in the room, that when it comes to cover of healthcare, a lot of us are very, very badly deprived of it. Or for that matter, even that awareness it's paltry, to say the least. But at the same point in time, and something that we were discussing earlier, Pawan, to that effect, that question, and perhaps COVID has been that black swan event that has made us question, where am I going to fund that treatment from? Do you see that one? Do you see that question getting asked enough? That's one part of the question. The second part, equally importantly, is when we talk from a very insurance-led perspective, and now we also have digital that has been thrown into the room, which is not just digitizing the healthcare system, it's digital transformation of the insurance, where this data is also going to real-time come in and plug into how health insurance works. How do you see this evolution from insurance 1.0 to insurance probably 2.0 or 3.0?
That's a tough one. Has COVID led to greater awareness? Yeah, people will talk a lot about it, but has it actually led to, people, taking more insurance? Sadly, the answer is no, right? Because it's the famous knowing-doing gap, right? That something. Intellectually I might agree with something, right? But will I act upon it? It's like everyone knows, right? I mean, going to bed early and, waking up early is a good idea. How many are going to do it? So, which takes me to the next 1.0 and 2.0, question that you were putting up. See, the essential challenge for insurance is that I don't know how it happened, but over last 22 years since the sector was liberalized, insurance, which is essentially a matter of trust, has become a matter of commodity. I mean, the cheapest insurance, the cheapest cover. I mean, that is just about the only claim that the industry is making, and that is essentially a marketing failure. I mean, in 20 years, we've seen every consumer category, differentiate and come up with segment-wise, solutions. So mobile phones have, today mobile phones are costing nearly as much as a top-end bike. Bikes are costing as much as a car, right? In every single category except insurance, where still the dominant paradigm is cheap, right? And therefore it becomes a chicken and egg situation. So say for example, you look at say US, the average for median income, the premium to income ratio for a median household is 10% of the income, right? And what that does is, by the way, US is no benchmark. They have their own problems. But what they get then right is that when adequate monies are being spent to purchase protection, then everything is covered, right? Right from your visit to GP, to your pharmacy, to your diagnostics. And that sets off a virtuous cycle. That, okay, this particular thing is helping me. Yeah, and therefore I must keep investing in it. That, however, has not happened in India. And I think 2.0 is about making insurance relevant to your, lived experience. And today, when you buy insurance, even the ones who are buying, it is for something which, God forbid, should not happen, or is very, very unlikely to happen, right? I mean, how many times in your life are you going to be hospitalized for more than 3 days, right? I mean, you take protection for that, but you don't seriously believe it is going to happen every couple of years or so. But how many times will you visit a doctor? How many times will you be getting into MRI? How many times will you be taking medicines? Now that is something that so far insurance industry has not had a clear answer to, and that is what most of insurtechs, whether B2B, B2C, or people like us, with our roots in crowdfunding, that is what we are trying to solve. That insurance should not just limit itself to a big catastrophe, but it should become part of your daily lived experience, right? I mean, if you partner with, say, companies like Zyla, so they can only recommend, right? They can't make you eat healthy or undergo a training regime. But at least when you're engaging, right, somehow you're creating a space for yourselves, right? You're not associated only with horrible events you don't want to think. I mean, who wants to get up and think, something will happen to my child, something will happen to my husband, my parents, right? So 2.0 is essentially, to my mind, how do you become relevant on a more relatable day-to-day basis? And that should be the next benchmark.
Thank you for that. For that matter, you got me thinking when you said that, a key question is cheap, not effective right now in today's parlance, right? As a consumer, I would also say it's a big question of trust. And very often, especially when there's a paid service, especially paid financial service, somewhere, and I would say it's a lacking of the larger marketing, like you rightly mentioned, right? What exudes trust? If the narrative that is pelted on me is that cheap is better, you just need a cover, check mark and go. But you're saying the right things, right? That the evolution to 2.0, as a consumer of that financial product of insurance, to the people who are, let's say, watching this panel right now, what would be the 2 or 3 questions that you would advise that they should ask of their financial service provider, specifically in insurance, so that they can make that right decision?
Yeah, I mean, if I could, one is to have a professional advisor. I mean, very few people are trained to actually identify the risks that you have, you and your family, and what are the available options in the market. And you can go to a site and look up a table which compares, X plans. This is not like buying an air ticket. I mean, everything gets you from Bombay to Delhi, right? Within broadly, similar parameters. I mean, this is a very evolved service, for which you need a professional. Now, whether that professional is an agent, whether it's your bank RM, whoever it is. So, first thing would be to get a good professional to do your risk audit. It sounds a very high-flying statement suited to extremely rich, but it is not. Actually, the more middle class you are, the more you need it. So after that, two things, particularly exclusions and inclusions. The regulator and the industry have tried a lot to simplify. I remember the contracts used to be 60, 70 page affairs. Now they are not. A reasonably literate person can go through contracts of most insurances and find out for themselves what exactly does the policy cover or not cover, and at least if not, you'll be able to identify what you don't know, and then you can of course approach the company and then clarify your doubts. And the third would be to be very clear about how to avail those services. I mean, a lot of times what happens is that when you are making a claim, you are not in a very composed state, right? By and large, I mean, even if it is something, forget about life and death, even if it is, say, your automobile, someone's banged, right? You're angry, you're disoriented, right? And at that point in time, for you to be able to avail the services correctly, you should have a prior knowledge as to how to file a claim. It's not rocket science. It's just plain laziness if you don't know how to file a claim, right? I'm not saying how to fight a claim in technical stuff, but yeah, basics you should know about your product and how to avail services. Yeah.
Right. That's definitely human behavior, right? But it's also human behavior, to your first point, that pay for that service, right? And as a human, especially as an Indian human, I would say, I'm not used to paying for my services. It's a freemium model. And Khushboo, that is the question. You mentioned something very interesting, and I took note of that. That was incentives for care also. Would a paid model in preventive healthcare, you of course are at the helm of running an organization that looks into that. How easy is it to, let's say, have people pay for today an online service in today's parlance, which of course is going to rejig the industry in the next 3 to 5 to 10 years, whatever. It will become more and more, I would say it would become more accustomed for people. It would become more customary for people to pay for it. But how do you therefore today, in that lack of where people are not willing to pay, there's this very strong focus on freemium model, how do you build a solution that will withstand the test of time?
Right. No, I think a great question. So you're right that in India, especially in healthcare, we'll sell our house if someone had to say, unfortunately get cancer in our family or a very extreme disease. When it comes to saving lives, we put all our savings, our gold and silvers, on the table. But when it comes to prevention, be it primary or secondary, right? By that I mean someone's healthy and you're trying to just keep them healthy, or someone has a disease or a symptom and you're trying to prevent a complication. It's tough to get money out of millions of people. I would say when we started in 2017. For the first 2 years, we onboarded 10,000 users who paid us a decent sum, averaging more than 1,000 per month for their care management. But can 1 crore people monthly pay me that sum? The answer is no. Right? So globally what has happened, and it is very, very apt for India, but interestingly, this is a global model. In healthcare, it's the same across the world, that the payer of insurance has to eventually take care of the person being insured, because it's important for them to manage the risk of their portfolio. As simple as that. So insurance today has woken up. We have found many B2B sponsors, for that matter, not just insurance. We have found great pharma partners, like Makarand was talking about digital innovation, who find an ROI when the patient is better. The patient adheres to the therapy, they are able to show better patient outcome. The doctors adapt to the therapy more. In insurance, there's lesser claims, so there's lesser cost. So what we've seen is that we've been able to align incentives with B2B partners who pay for this care at scale. Now the question then comes, as you rightly said, is trust and utilization, right? Because healthcare is not a commodity. It is not something, it's not a food I deliver someone's home. It could be cold or hot, I'll still be okay, or a ill-fitted dress. It is really a matter of life. So healthcare is based on trust, and for the end person who's not paying out of pocket, now for them to utilize it consistently requires crazy amounts of trust building. So I think the one thing that has worked for us, and when I talk to my partners, I show off our technology and products and processes and team, but my clients tell me that Khushboo, your moat is none of that. It is the empathy of care that you possess, and that is why patients engage, right? So I would say incentives have to align for the sponsor and for the one availing the care in a way that you can eventually show outcomes, right? It becomes a win-win-win.
Great summary of that, actually. And when we talk about the larger ecosystem, perhaps it's the pharma sector which really holds the entire upstream supply chain, or the upstream value chain of this. And Makarand, at that one, let me get back to you. We have spoken about a lot of things here. We have spoken about different models. We have spoken about different levels of trust. We have spoken about moving from plain data to the value that data offers. What are the top, let's say, 2 or 3 trends that you see that the evolution we are going through currently, at the end of this tunnel, what are those 2 or 3 big things that are going to really shake up the way pharma is today?
Okay, so there are 4 or 5 areas which I feel are important. First and foremost is access. When I say access, what I mean to say is that today when we visualize data and healthcare, for most of us it's about the Apple Watch and some fancy devices which are very sexy and very tech, high-tech stuff. According to me, where pharma would really will be able to make a mark is to marry the high-tech with the low-tech. Why? And I'll answer the question why is because on an average, a medium to a large size pharma company has around 3,500 people on the ground who work across the country. We have companies who have people close to even 8 to 10,000 people. Now, if you see, even the top 50 companies put together would cover a large portion of the country into the to the depths and the breadths of the nation. Number one. Now, the point is that if there is a way in which we can really leverage that to not only generate data, capture it and make use of it, I think it's a question of brainstorming this, but it can be done. But to answer your question, first is that because of the sheer penetration and access, pharma will be in the forefront of data generation, structuring and usage, number one. Number two is that we have resources like the ASHA workers, for instance. Now there are companies who are pharma and non-pharma healthcare companies who have started really helping them. I think this is one area where it can be done. And I keep on coming back to the point is not always high tech is the best tech. It's the combination of high tech and low tech. It's sometimes easier to order a pizza online than to find a right healthcare service or ambulance when you need it. And I think these are the areas where pharma can really help. And I know that there are companies who are taking steps to really do that. So one, leverage the current field force to partner with government organizations and healthcare agencies to do that. And number two is, okay, this is one. The second point is, there is one more thing which reaches every household which a pharma produces is the medicine itself. For instance, Combiflam, I mean, it's Sanofi brand. We manufacture 1.4 billion tablets in a year. That means it reaches 1.4 billion individuals every year. Just one simple
One tablet in
one
Indian
tablet,
actually right
Indian,
now.
yeah, almost like that. So, I mean, this is just an example I'm giving. Quoting is because what I'm trying to say is that the medication itself is a vehicle which reaches a patient's home. I think with some innovation there, if pharma is working on, it would be a great tool for if you marry digital with a pharma pack, it can create wonders in changing people's lives. There are companies who are actually marrying technology of dose reminders, for instance, on a pack to a patient. But anyway, these are, again, I would say dose reminder is good, but the point is if a patient is on a medication, today it is expected to manage the disease. If that medication and the pack is helping me to further prevent complications and track it, monitor it and ensure better health for me, it's a great stuff. So these are few areas which are a combination of high-tech and low-tech,
Right.
but with great access is what we want to do.
No, thank you for saying that, because the combination of high-tech, low-tech and the larger change management that we started this conversation with also is so important. And in the interest of time, I'll move to the second last question, so to say. And Anil, I will equate back to you in terms of, the larger healthcare professionals that we have. There's, of course, so much that industry can do to help them evolve. But there is also this normative ecosystem that has to come together to ensure that nobody gets left behind in terms of the healthcare professionals. What role do you see the government, the social sector, the education structure play in really creating a more aware healthcare professional, somebody who can even ask the right questions?
So, and rightly said, I think so. The government is really playing a big role now, right? So one of the examples I would say is recently, I think so. We have seen government partnering with Google Cloud to set up cloud ICU labs, and they've already done for few states where HCPs are engaging with the end users over this medium. They're diagnosing it. They're giving the reports, they're sharing the reports, they're doing the entire stuff, right? That's one we have seen it. Similarly, if you've heard about initiative called e-Sanjeevani, which has really picked up a lot, right? So I think so. If I mention about 8 to 10 states, has really picked up, right? So which is again into like telehealth and telemedicine kind of something. It gives you online OPD and that. This is a very big initiative with government has taken it up along with the pharma companies, right? And it's 10 states are actively following it, and then we will propagating to other states also, right? One of the another initiative which I have seen government, like if you see the telemedicine, they have free. They have reached out to about 10 CR in general, and they've been and it's going on. This journey is going on, right? Coming back to the why that numbers will keep on going. Coming back to the revenue numbers, like if I see 2023 revenue numbers for a digital health stuff, it's like about $170 billion, right? And M-Health, where government also there's a lot of promotion which comes from government, takes a very bigger chunk pie. It's about like 40% of that bigger pie falls into that area, right? And this makes government to participate in all those initiatives.
Sure. So you mentioned very interestingly so many government initiatives that are there, and to close it, Dr. Sethi, I'll go back to what you said initially. Data is a very important currency when it comes into forming policies. These policies that Anil also spoke about, and the caveat I'll use is I'm currently reading a lot around the gender disparity in the data that we collect and how it doesn't really speak. And I'll not be surprised if it is the same lack of depth of data that is there in different markers, whether it is the urban-rural divide, whether it is based just on the gender that I said, or perhaps even, various factors that we don't know. And a common critique of AI, specifically in frontier technology, is that it reflects the bias that has been there for the last 30-40 years. But given these strides in things like ChatGPT, which are more, I would say it's more critical than the previous AI evolutions, how do we address, one, that bias? Second, what could be these, what are these important questions we need to ask frontier technologies today so that we can actually bridge the divide rather than deepen it further?
Sure. Thank you, Dipakshi. So I think the answer to that lies in the question itself, because when you said that there's more advanced technologies like ChatGPT and then there's previous generation AI approaches, both of them are necessary. The way I see it is that AI itself is agnostic, and it can be used to illuminate the same biases that exist in the data. And we have been doing that in our lab for our papers. One of our AAAI papers was exactly on the lines of what could AI models tell us about the life expectancy inequality in the United States from the data, and we learned some interesting things from that. So it is, I think, getting aware that AI may be biased unless we put AI to the same use of illuminating the biases is the first step towards that. Secondly, I would just like to say that that models like ChatGPT are great and they are the future. However, explainability in AI is something that builds trust, something that ChatGPT may not be so great at doing. So the way forward is going to be explainable AI, which can not just illuminate the biases, but also explain why did that bias exist. And there have been approaches around that. For example, the good old probabilistic graphical models, which actually even clinicians can explore and understand, and how do we actually use those frameworks in the perspective of the newer approaches. So to close it off, I would just say that essentially data will always have biases. It is almost impossible that data can be bias-free. We have to set an intent that we have to illuminate the biases. We have been doing that for the ICU space as well, that for example, there have been a lot of AI models developed for ICU settings, including our own. But do these perform equally well on genders? Do these perform equally well on socioeconomic strata, on races? So I think the intent and the way towards that is actually put AI to use for the same purpose that we think it is biased against. So that may be step number one.
Thank you very much for that. For that matter, I'd just add that one part. I don't think so data would be biased. Data is as objective as data can be. It would be the person drawing that inference from data, and how do we really address those biases also,
So,
right?
no, yeah, thank you. What I meant was databases may be biased. I'll give an example. Imagine a bank which has a rule that they'll only give credit to people who are older than 18 years unless the person who's younger than 18 years old, their parents are known to them and the parents are really rich, right? So now this data generating mechanism will create a database at the back end in which every person who is younger than 18 years old will actually end up paying back the credit because they had rich parents and the parents were known to the bank. So the data generating mechanism may be biased, in which case the database also is biased. And no ChatGPT, no AI model, it'll actually predict that give credit to people who are less than 18 years old because they always pay back credit. So that's what I actually meant by it. So we have to understand how data are generated. What are the mechanisms, what are the data generating processes through which these come, and we need to illuminate those.
Thank you. With that, I think we are on time, right? And thank you very much, everybody who's on the panel today. And great discussion, something I really hope we are able to carry into the days that come by as well. Thank you very much.
Give me an insight that teleconsultations are happening as of today once we are done and dusted with the COVID. We have seen there was a peak during the COVID. How many actually are happening? I'm not asking about stats for East and Evening because I'm not looking forward to that. How many others? Do you see there's still a scope in telemedicine in India?
That is the only way out for India. India has one of the lowest medical availability, right? And if we want to have outcomes similar to, say, Western Europe or North America, the current model, it won't work.
But there's also a study, I'm sorry I'm interrupting you, that before the COVID began in US, we do not do any studies typically here in India, so I'll refer to the data that is being used in US, that during the period of January to February, the teleconsultation stats were at 0.2%, while in March they were at 40% when the COVID was at its peak in 2019 and 20 in US, and now there is a decline. Are we doing any monitoring here that what is the decline ratios, anything?
I mean, so say, you see what happens is that these crises, we need to have use of
I'm not sure about the audience at the back.
They are in their live streaming, so you'll not be.
So you see, what happens is that when COVID was raging, every consultation was digital.
Absolutely.
Only calling up your.
Yeah, that's
so
right.
what that does is that shifts the mindset in the customers. That look, prior to COVID, if you would have had asked me, do I want a doctor on call? I would say that is neither here nor there, right? That is my mother, right? Not a doctor. But once normalcy has returned, people have found out that there are specific occasions and problems that digital consulting, teleconsultation solves. So say for example, you're in your office, you're driving, you're busy, right? Now physical consulting is not possible, even if you can afford it, right? So what that does is that expands the market. It's not that physical consultations have gone down, it is that digital consultations have created a space of their own.
Okay.
So
that's
apart to add,
Can I?
yeah, please.
I'll just add some empirical evidence. Again, I don't have the stats, but I do see that I don't consult anymore, but many of my consultant friends still run the service, and what I'm trying to say is that exactly what has just been articulated, that previously doctors did not think that this is a mode through which this was not a channel through which people might want to, but now both people and doctors are seeing that as a channel. It will not be the same as the COVID time, because it's hard to replace the human touch. But as I said, I think once the mind knows it's expanded, it's hard to come back to the same.
That's what I was saying, was that, apart from that time crunch that we usually face, or, an emergency that we want to consult somebody over a video call or something, how many consultations are actually happening? That's what my question is.
Happening, I don't have that.
Yeah, I mean, I'll just add there. See, we are thinking of telehealth in a very limited capacity right now when we think of a doctor consult. What we have to understand is that digital health is very rapidly evolving, and sometimes we think that it's slow and it was just temporary, but it's not, right? So just to give you an example, the government has already covered 40 crore Indians, right, out of the 140 crores with Aabha ID. So Aabha ID is your longitudinal digital profile, which will enable any provider, doctor, hospital across the country to access your longitudinal record as easily as UPI, right, just with an OTP. Now what that will mean is that all of us will have a central repository, an electronic medical record which did not exist. It will create a plethora of organizations, companies, technologists creating algorithms on top of that data, able people like Dr. Sethi to predict risk, to put people on a care pathway. So what we are thinking of right now is telemedicine is an ad hoc doctor consult. That is just the starting point, trust me, and one part of the story. Imagine what that cannot do today. In a doctor consult, no one later is able to follow up with you whether the treatment helped you, whether you need a second line of treatment, whether you actually took the interventions, be it lifestyle or medical, to improve your health, whether there are symptoms, which means there's a complication, it needs action, do you need a preventive test. This is a continuity of care that will come in when there is enough amount of data. And telehealth, trust me, we're all here, in the next 3 to 5 years, the government is going to change the shape of healthcare. And it will be as crazy as UPI and GST suddenly changed the face.
So what's the future for private players? Because if the government has taken it on a stride on mode.
No, the government cannot do it alone, right? The government is going to create an ecosystem and an infrastructure and a platform, right? And then there's going to be crazy amounts of PPP partnerships. So imagine the government can be a provider or an insurer, but it cannot be a Medanta, Fortis or Apollo, right?
For sure.
So it creates, it's the same as, you know, how on the finance, digital finance side it's working. The government creates an ecosystem and then a lot of private players jump in. And, you know, even Paytm or Google Pay use the UPI framework. It's exactly the same and it's moving. Trust me, I was at the FICCI conference and I was amazed to hear Dr. R.S. Sharma, who's the president of, who's leading the IIIT affair at NHA. It is outstanding the pace at which they're working. The words he was using, I mean, only my CTO uses with me. So I was amazed beyond doubt.
What's the name, if I may have for reference?
Dr. R.S. Sharma. He's just retired though, and another person has taken up as a CEO.
Thanks. Thank you so much. Anybody?
All right, so with that, we will close the session and thank you very much, everybody.